Michael Nicoletti is also no longer on the task force. We'll be getting a different replacement for Dora. Margaret Ochoa.
Good morning.
Hello, good to see you. Colleen O'Neill, I know I just saw you somewhere.
That's all good. Yes, I'm here.
Yes, thank you again. And representing Disability Law today, we have Ginger Geisinger filling in for Sarah.
Good morning.
Welcome, Ginger. Rashawn Kalatar. Put a question mark on that one. Brynja. I don't see. Okay. Nikki.
I'm here.
Good morning.
Good morning.
Kathy Wells, we saw you dancing earlier.
Good morning.
Good morning. And Donna Wilson.
Good morning.
Hi, Donna. Good to see you.
Likewise.
Good to see you always. And representing Denver Health Medical Center, we have a substitute, Heather. And Heather, I cannot say your last name. Can you help me?
Yes, it's Kazmarek.
Kazmarek. I was probably going to get it close. Welcome. And you're filling in today for Kelsey.
Yes, thank you.
Thank you for being here with us. Jade Woodard.
Good morning, everyone.
Good morning, Jade. And for the record, I am here. All right. Thank you all. Moving on to our meeting minutes of April 5th, 2003. Has everybody had an opportunity, just a show of hands, to review those meeting minutes? Those were sent out in your materials. Just head nods. Great. All right. Are there any additions, corrections, deletions that you would like to make known on the record? And I'm searching all my screens. I see no hands up, looking for amendments to the minutes. All right, if somebody could please make a motion to pass the April 5th minutes and say who you are, and then if we could have a second.
Michelle Dossiel, motion.
Thank you, Michelle.
Kathy Wells, I'll second.
Thank you, Kathy. And I'll do this in the reverse. Is there anybody who is opposed to the passage of the April 5th, 2023 meeting minutes? Okay, I see none. Fantastic. All right. Just lastly, just wanted to sort of update the panel on just some legislative developments this year. I know many of you on this panel and have seen you in the halls of the state capitol for the past 6 months or so. But for those who frequent the Capitol less, by the way, congratulations, you're very fortunate for that. Just wanted to give a little legislative news. So the governor just signed a proposal, if you will, that is creating a child welfare interim committee for this summer. Over the past several months, a number of issues came up to the General Assembly, and General Assembly members really did have concerns about the functioning and the well-being of child welfare and the state of it. So essentially, an interim committee was signed into law. That committee will meet 5 times. They are covering a multitude of issues, really what I call from the front door, entry level, right, when people enter into the child welfare system, all the way to the back end, right, with even, foster youth, kids leaving the system, all of that. So as you can imagine, the notion of mandatory reporting, intake, assessments, a lot of the issues that we've talked about and will continue to talk about will likely become a topic of conversation for this interim committee. So I wanted to alert you to that. I'm looking at my team. Jordan is on screen somewhere, but we will go ahead and include a link to that interim committee. They will be public hearings. So if you want to follow those hearings and see how they impact not only your professional world, but also this specific topic of mandatory reporting, you will have that information. The only other thing I can say is that it is likely we will be asked to report out on this task force. The Ombudsman Office is a requested panelist for this committee, and so we likely will be required to report out, and we will be giving them a summary of the work we do here. So I just wanted to highlight that for all of you and let you know that that work is ongoing. Are there any questions about that?
Do you know who the members of the committee are and how they were chosen?
You know, I do not at this time know who the members of the committee are. I do know the committee is being chaired by Representative Michelson Janae. And also, oh, Jill, you seem to have a list of all the members. Okay, great. And also Mary Young, I know is her co-chair. It looks like there is a list of members, so we'll let Jill put that into the chat. So that's fantastic. For those of you, who are familiar with interim committees, oftentimes interim committees are formed really so that we can have more meaningful time to explore various substantive issues. The benefit, if you will, is also that based upon those hearings, that legislative group can put forth 5 bills into the future for next legislative session. So it serves as not only an information gathering session, but also as a place where legislators can begin to formulate ideas for the upcoming legislative session. So with that, other questions? Okay. I think that is it for me, Trace.
That is it. Thanks, Stephanie, and thanks, everyone. More to come on that, and thanks, Jill, for sharing the list. So moving on to the next slide, a couple of things. We're going to kind of, basically where are we now, where are we going, and then we'll get into today's discussion. So I wanted to bring up the April 5th recap. This was sent out to you all via email with Jordan. I want to remind you all that, obviously this is different from minutes, right? So we don't expect you to read the minutes. While we appreciate them, Alexis, are very robust. And this is really the way to see how we as a facilitation team are capturing the discussion at hand, what we're hearing, how we're seeing the priorities. And then this is what's informing the interim report and ultimately the report. So it is super important that you all read this when they come out via email. And if you have feedback, Jordan also often offers a deadline of feedback because we want to just keep things moving. So I just wanted to remind folks of that. I also wanted to, I know that a number of you have had a chance to read it. So I did want to just give a moment if there were any comments or questions in particular to the April 5th recap, any comments, questions, concerns about anything you saw in that recap. Okay. I'm trying to get better at my wait time, but I'm going to move us on. So if you haven't had a chance to review it, you can after this meeting, also when we send, this recap as well. But again, we'll kind of we'll put deadlines on those in an effort to just move us forward. And it's really going to help us inform how we're writing that report. So, all right, moving on from there. Want to make sure that we're clear on what we're reviewing and as it relates to all of the directives and kind of where we are. So again, we have 19 directives. We're currently in the middle of these 3 that you'll see highlighted at the top, analyzing the effectiveness of mandatory reporting. We are clearly spending a lot of time in that one, and Doris will kind of talk about that as it relates to the roadmap. Analyzing the disproportionate impacts of mandatory reporting. We've had both explicit discussions, but we also see that as being woven into the variety of these conversations as we continue on. And then alternative process and services for children and families. So really, while we're talking about the effectiveness piece, we're also trying to focus ourselves on solution side, right? Which is really this alternative process and services for children and families. So what are the ideas that task force members have if there is an idea around alternative process and services? The rest, I'm not going to read through each of these, but we just wanted to make sure that you all kind of saw in the frame of all directives, which ones we were explicitly focused on currently. Any questions there? And thanks for toggling kind of between those, Jordan. Appreciate that. Okay. we're flying through. Appreciate it. Everyone's doing their homework, which is great. So a lot of these things, again, don't want to be duplicative in our communications, but we just want to make sure that we continue to bring folks back to the same page on where are we headed. So with that, I'm going to hand it over to Doris, kind of, again, coming back to this roadmap idea and where we're headed. So Doris, I'll hand it over to you, and Jordan, if you want to go to the next slide.
Fantastic, thank you. So over the next series of meetings, we're going to dive in a bit by mandatory reporter type so that we can get a better sense of what are the nuances around the reason for reporting from a particular group. What are some of the challenges that they see? What are some of the needs that they see? And lastly, and most importantly, what might be some alternative approaches for those groups to meet the needs of families and meet their needs in making reports to connect families to resources, services, and keep kids safe. So we're going to spend some time really diving into the nuance again of each of these reporter types and individuals that are involved in the reporting of or receiving reports on child abuse and neglect. You see mapped out that we're going to be meeting. I think in the last meeting we mapped out with our regular meetings every other month. We're including the interim meetings in this roadmap schedule. We're going to start today with our medical and mental health professionals and hearing from members of this group who represent those professional reporters in those two categories. And then we're going to spend some time with our partners at Casey Family Programs, really diving into the data relative to each of the mandatory reporting groups so that we can understand what the data in Colorado looks like, how it compares to national data, and have the data as part of our conversation and looking at how families move through the system when they're reported on by a particular professional reporting group. And then we're going to, start with the different mandatory reporting categories. We're going to move into who receives the calls. So hearing from members who are charged with receiving reports of child abuse and neglect and assessing those, screening those in or out, and the subsequent process that happens with families. Next slide, please. Awesome, thank you. Following hearing from who receives the reports of child abuse and neglect, we'll hear from who monitors the system. So those that are monitoring whether or not reports happen, what happens if reports aren't made and a child is in fact in need, so that we can then map out, what is the experience from families, what happens when reports are received, and then look at that monitoring piece. And then in November, we're going to spend a whole meeting focused on the interim report because we want to make sure that there is an opportunity for input, reflection, and refinement before the report actually gets submitted. And then we'll wrap up the year with talking about some national reform efforts. All of you may be aware that there are a number of states that are having conversations about mandatory reporting, in part because of the disproportionate impact that mandatory reporting laws have and the mismatch between intent behind them and actual outcomes and experiences. So we'll want to see whether there are some strategies and approaches that are emerging in other places that we can use to inform this group's thinking on what might be alternative approaches to existing mandatory reporting laws and approaches. I'm going to pause there and see if there are any questions from the group on where we're headed.
Doris, we have a question in the chat. Is 11/10
an accurate date?
Yep.
I think they're saying that because it ends up on a Friday.
Oh, look at you looking at the calendar.
Yeah, I have November 8th.
I have no
Oh, my
idea what
goodness.
November 10th is.
We can double check on our end. Appreciate that kind of call out. So we'll double check that and we'll clear that up in the recap as well.
Thank you, Bonnie.
Folks know.
She said it's also a holiday.
What? All right, we're definitely going to clear that up then. Thanks.
Yes,
Appreciate that.
indeed. Or else the four of us are going to be here by ourselves.
Holiday, right?
All right, fantastic. Oh, it's Veterans Day.
We'll make that right.
For sure. Any other questions, comments, concerns? I'm trying to scan my little boxes.
Okay, seeing Jordan's comment, so we can correct it right now. It is November 8th.
All right, fantastic. Thank you. Nice catch. All right, hearing none, I'll hand it back over to you, Trace.
Perfect. Thanks, y'all. I'm eager to get us to stop talking and for you all to start talking. So I'm excited for this next portion. So we're kind of zooming out from the 30,000 feet, zooming into today's conversation and coming back to this directive. As you all know, this is a directive that you have expressed. We need to ensure that we do our due diligence around. There are a lot of different nuances here, a lot of different perspectives, experiences. And so really excited today. We're kicking off these series of panels on the professional side. And so I'm really excited of who we have gathered today, but really this is the directive: is mandatory reporting effective in serving children and families in Colorado? Broad question, right? So we're going to dive in and get a little deeper on that, a little bit more specific. So if you want to go to the next slide, or that might actually be the end of the slides. Okay. So last slide here is, so we've taken a stab, and I understand, I just want to name first off, this is not the end all be all of buckets of why are mandatory reporters making calls. And we know that. However, for the purposes of this group, we need to start moving forward and starting with something to work from. And so what we've done is gone over the past conversations, the past minutes, the past notes, and really honing on the conversations to determine like, what are the main buckets of why mandatory reporters are making calls. And really that kind of helps inform these discussions. So these are the three buckets that we came up with. I want to give you a chance to respond to those briefly, but we're just going to, this is a starting point, and then we're going to move the conversation on. So one, concerns about a safety of a child, right? We know that is one that we've heard broadly across the board. I have a kid in whatever setting, and I'm concerned about what's going on, either what I've heard, what I've seen, and so I make a call. Number two, desire to connect families and children with resources and services. So again, I know that we're going to talk a lot about that on the solution side. Sometimes people feel this is the best way to connect them to resources and services because they're not quite sure what else resource and services that they should be connecting to. And number three, concerns about legal liability for failing to report. And so the panel discussion that we're going to have today, which we're going to do introductions in just a minute, you all had the opportunity to read kind of like baseline where they were coming from, both in response to these buckets, but also just generally the challenges they see in their professional space. So I want to make sure that, does anybody have any questions or comments on this piece before we get into that discussion? Because I want folks to be able to have a chance to really listen to the panelists on this one and a number of other questions. So any quick questions or comments here? It's a tough crowd today. Okay. Jordan, I think that was our last slide here. So again, that's a grounding piece of what we've all heard from you and kind of how we see ourselves moving through this discussion. It's not something that we continually to point back to, but we do want to ground in that's what we've heard. So today, super excited to introduce our panel. We are one person down with Ida last minute not being able to join us, but we have three incredible folks, 2 task force members and 1 proxy member that we are really grateful for you all joining today. And Doris and I are going to kind of lead us through a discussion. But as you know, that you all had a chance to really read responses from folks. We wanted to build a baseline, so we didn't spend the entire time hearing baseline answers. We wanted to get to the solution side, to the ideas side, but I'm going to pause there and do a quick round of introductions. And so what I'd really love to do is give the folks, let's do a highlight too. Do you know how to spotlight, Jordan or Alexis? Are you on? Okay, Alexis, if you can spotlight folks. So I'm going to bring in Dr. Kathy Wells, Dr. Donna L. Wilson, and Heather. I might butcher this last name, so please correct me. I'm going to say Kazmierek.
Yeah, that's good.
I did it?
Yeah.
Perfect. Okay, so what I'd love for you all to do is to actually give us a brief introduction of yourself as you see fit for this conversation. But this panel is really medical mental health professionals, and we have a variety of perspectives, a variety of experiences, as you'll hear. And so Heather, appreciate you kind of like being willing to jump in. I know that I'm not sure that you've been to any of our meetings before, but in our call, we were able to kind of catch Heather up as to where things have been. So I think, Heather, it looks like you're live and on the floor right now. So we understand if you all of a sudden have to run and get anything done, but we appreciate you spending your time here. And then Alexis, if you could bring in, there we go, Dr. Wilson, thanks for being here. So let's do a quick round of intros. Where are you at now professionally, but also kind of like, what are you bringing to this conversation from your perspective, just so folks understand, and then we'll kind of dive into the questions. So I'm going to start with Dr. Wells, if you could go ahead and introduce yourself.
Good morning, everyone. So I am currently, I'm a pediatrician, and I have a board subspecialty in child abuse pediatrics. I am currently the director of the Kemp Center and the section head for child abuse pediatrics, and a professor at University of Colorado. And my medical practice is based at Children's Hospital, but we cover the region. What I hope I bring to this conversation is about 25 plus years of practice. So I practice as a general pediatrician in a small community, and understand the nuances, or I believe I understand the nuances for the general practicing community, at least physical health providers. And then over 20 years, and Stephanie, correct me on this, maybe it's close to 25 and 30. So 25 years specializing in child abuse pediatrics and focusing on the complexities of the system. And in that work, I've spent time really embedded in a system where I was working daily with caseworkers and law enforcement and healthcare providers in response to cases that came in at Denver County. So I hope I bring a breadth of sort of seeing what is coming in the door in terms of reports, hearing the challenges that healthcare providers have shared. I also did ping, and I'm representing the Colorado chapter of the American Academy of Pediatrics. So I've had conversations with general pediatricians and other general health providers in terms of some of the challenges that they face. So I'm hoping to bring all those perspectives into this complex conversation. Thanks for having me here.
Thanks, Dr. Wells. Appreciate that. And I'll say, you kept saying that you hope you bring it. I know you're going to bring it. So you're being awfully humble with that. So appreciate you being here and appreciate you bringing that experience. Dr. Wilson, if you wouldn't mind, would love to hear more from you.
Sure. Hi, I'm Donna Wilson, and I am currently the Director of Operations and Community Engagement at WellPower, formerly known as the Mental Health Center of Denver. I have over 30 years of both national and local experience, mainly in child welfare. Started Adams County's very first child protection treatment team. So that's something I hold very near and dear to my heart. I've been a licensed professional counselor since 2000, so about 23 years. I also ran the Colorado Disparities Resource Center, which was a statewide resource for Colorado on collecting all of the disproportionality and disparities data in our state, and offered solutions for teams. Started the Child Welfare Training System, which Kathy is now overseeing. So also did this national project with Casey Family Programs, where I oversaw a breakthrough series collaborative on safety and risk assessments. And we run together 21 teams in 3 tribes on trying to really unpack what safety and risk really has meant. I've also served as an honorary professor at the University of Colorado, Denver, teaching multicultural counseling. So I have a lot of different lenses. I consider myself a trifecta: research, practice, and policy, because I've straddled all three of those places, worked at National Conference of State Legislatures, and oversaw their child welfare and early care and education teams. So I can go on and on. My vita is pretty extensive, and I won't bore you with all the details, but what I'm hoping to do today is just to really have us think about, and I think Doris kicked it off, talking about the intent versus the impact of this law, because it has unprecedented, disproportionate outcomes for children and families of color. And so I just want us to be thinking about that, the lifelong consequences of calling in things that may not reach the threshold of safety and risk is something that we have to really, really just unpack. So happy to be here.
Appreciate you being here, and you weren't boring me at all. I was just like, wow, what else have we done? This is amazing. So thank you so much for sharing, Dr. Wilson. Really appreciate that. And Heather, I'm watching your face and you're like, wow, these people are so we're really excited for your perspective and to learn a little bit more about you. Obviously, we've got some incredible folks at the table, yourself included. And so, yeah, I would love for you, appreciate you standing in as a proxy. So appreciate the kind of challenge of that. But two, you have a really unique perspective. So I would love for you to share kind of where you are and what brings you to this conversation today.
Sure. I'm currently the neonatal ICU social worker at Denver Health. I have been working in this position for just over a year. I actually came to Denver Health from University Hospital, where I worked for 5 years. So I have 6 years of experience working in the medical setting in terms of making DHS reports and collaborating with our counties. I worked at University Hospital in their neonatal ICU as well as with the adult patient population. So I have about 3 years of covering the patient population of the neonatal ICU, as well as cross-covering mother, baby, families, and patients at University and Denver Health, as well as covering the pediatric patient population at Denver Health as well. Prior to working in the hospital system, I actually was a permanency caseworker with Arapahoe County. Michelle, I was on Bodie Burns's permanency team, and I had a few other years of experience prior to that, but obviously I do not have anywhere near the years of experience that Dr. Wells and Dr. Wilson have at 25 and 30 years of experience, but I do have the 6 years of experience that I can bring to this conversation from working in the medical setting.
Love it, Heather. And you're in it, right? You're in it right now. And that's an invaluable experience. So we just really appreciate you. I know you're busy too. So we really appreciate you taking the time. Doris, if you don't mind, I'm going to kind of start us with one of the questions that we saw in the survey is just kind of honestly, because I saw the questions differed from everyone. So I would love for folks to speak kind of to their answer, because we got very different answers in the survey piece. And then Doris, we can just kind of go from there. But really, I'd say to you all, this is your panel. We want to make sure that we're having a robust discussion, that we're talking around the things that you, from your perspective, are wanting to talk about. So I'm going to kick us off, but then let's see where we all want to take it. And then we're going to have a chance for folks to come in and ask questions as well. I also want to name that we're going to spend some time really like level setting in those challenges. So Dr. Wells, you talked about like you hear these challenges, you hear from folks, and I'm sure all of you have the ability to say, this is what I hear and this is what I've experienced. So we're going to spend some time in that. And we really want to make sure that we also get to that solution side too. So from your experience and from your perspective, what alternative ideas do you have? Like, what would this look like? So that we can really kind of get your expertise around that as well. So we'll kind of split the conversation up that way, looking at the challenges and then looking at what could this look like. So I'm going to start with this first question. So going back to those kind of broad reasons as to like why folks file reports. One, concerning the safety of a child. Two, desiring to connect, children and family with resources. And three, concerns about legal liability for failing to report. Everyone said something different. So that's why I want to start here. So in your experience, which of these broad categories is the reason most often cited for making a report in these settings? And which is the reason least cited? And like, and why, right? What are the challenges behind that? So I want to start us there. And Dr. Wells, just for sake of kicking it off, I'm going to kick it to you first.
Yeah, so this was, so answering this question was challenging because I want to sort of frame that there are, in the healthcare profession, for example, there are folks in different settings. I would say in general, in my experience, the most common reason is there's concern of safety. And the reason for that is that most healthcare professionals really value their relationship with the family, really value that connection, really want to make sure that they're doing what they can to engage in them. We have a lot of confidentiality laws. We have a lot of, really goals to try to make sure that we're engaging with the families. And in my experience, oftentimes, both myself and what I'm hearing from my colleagues is that it really is when it rises to the level of, I'm really concerned, right? Like we've done everything we can and the family won't engage. And that even includes in mental health situations, right? So we're really, really worried about this child and they're not engaging, or we've lost them to follow up. This is a newborn that we had worries about and they were supposed to be in over a month ago and we haven't seen them and we're worried. And in fact, some of the studies that have been done, I think we had a large study done in our field in the late 2000s, 2007, 2008, really asked pediatricians and pediatric healthcare providers about whether they reported. And about 20% of the time, even when they were very sure or pretty sure that it was abuse, they actually didn't report. And they didn't report because they were either afraid of losing the family to their follow-up. They actually had a relationship and they wanted to maintain that. And they felt like that was the safest thing for the family. Or they didn't trust that the system would actually do what it needed to do. They had perhaps bad experiences previously. So from my lens, most of the time what my experience was is that I've kind of done everything I can, and I'm really worried about, that this is a safety issue. Secondly, I would say that, yeah, there are certainly times when there are concerns that this family needs resources, and I think the best place to turn them is to child welfare. But again, because of that, the importance of that connected relationship, I feel like that's much less common for physical health providers because they're afraid of losing that relationship. And the last thing is liability. I think it's there, but to be really honest, I think it's not, certainly not from the providers. I think sometimes when that issue comes up, it's really from our systems, our hospital systems, our other legal systems that are telling us, if you don't report, you could be liable. And the other thing that I'll say about this is it's very complicated if we're talking about serious physical abuse or sexual abuse versus neglect. And I think it's probably appropriate that in some ways you started with a medical physical health provider, because I think everybody's pretty aware that some of these laws really came from concerns about serious physical abuse that was not being reported by health providers. And in fact, in all fairness, early laws really came from a desire to have better equity. And one of the things that I'm going to challenge this group, and I'm challenging myself to think about, and Dr. Wilson, I'm really, this is an exciting conversation, because I think in some ways we could argue that if we removed some sort of mandate, could we be opening the door to increased bias? Could we be opening the door to someone who says, I'm not necessarily mandated, and I'm more worried about this family because they look a certain way, or they seem a certain way, or they have a certain sort of resources, as opposed to this family who looks a lot more like my family. We know those biases exist, right? And I think our challenge as a group is to really say, how do we diminish those without sometimes unintended consequences of good intentions, or that we actually potentially make things worse? So my answer to that question is in my experience, it's really more around that safety concern. And when it really rises to that level of, I just don't know what else to do, and I'm really, really worried.
Thanks, Dr. Wells. Appreciate that. And I want to give, again, as a grounding for this, and I know you brought up a lot of things that I think we could dive into, but want to give a chance, Dr. Wilson, and then to Heather, to kind of answer from your perspective. One, either to this is similar. I think per these answers, there's just different nuances in different places. So Dr. Wilson, would love to hear kind of your thoughts around this.
Yeah, I was nodding my head a lot when Dr. Wells was talking, because I think there are similarities in behavioral health, right? Like we too are worried about establishing and maintaining and preserving that therapeutic alliance, right? And when you make a report, one of the things that we pride ourselves on is being transparent with families and letting them know we've made a report, we've had this concern. But I'm not going to stray away from my answer, because I do think that most often times what we see are reports are happening because people have needs and resources, and they are afraid that those resources or those deficits of being able to provide for basic level care is going to lead into a neglectful or possibly an abusive situation. So in their mind, they're thinking this is like preventative. We're going to get in there and get in front of this and, get this in front of CPS because they have all the resources. So I think that there is this misconception of what CPS is and what they do and what they are a gateway for providing. But I don't often hear like, I'm concerned about this safety risk. Sometimes it is, but I think more often than not, it's really about those resources and trying to make those connections. I think one of the biggest disconnects that I see is that there isn't a solid understanding between safety and risk, between abuse and neglect. And that's the thing that, back in the early 2000s that I was doing in this Breakthrough Series collaborative with Casey Family Programs. Can we operationalize a national definition? And hello, we can't even do a local statewide definition because, we have one, but I think the way that it's implemented is very different because we are state supervised and county administered. So, there's all these different nuances that happen. But again, I stick behind to what I said, resources is the way that people are going. I think there is some fear, like Dr. Wells said, around failure to report and what that means for them professionally, but I don't think that that's the main driver. And I think people are confused about what constitutes or reaches that threshold of the definitions in Colorado around safety and risk.
Thanks so much for that, Dr. Wilson. Appreciate that. And so it's interesting to hear just kind of the differences between the physical piece, Dr. Wells, that you were talking around, and then when you're in these more like behavioral health settings, really it's like you see a need and you see this need more from like a resource perspective. So Heather, I'm curious, as someone, you're kind of like, you don't need to tie these together. You could be having a very different experience, but want to hear from your perspective. It sounds like you were kind of the primary person that would be in this role. So obviously I understand there's a big challenge in answering this question, but yeah, I would love to hear from your perspective. What do you think is there?
Yeah, and I think my perspective is just a little bit different in the sense that a lot of times here in the hospital, the families that we're working with in the neonatal ICU or on the mother baby unit, we are working with them because of maternal substance use during pregnancy by far and large. And with that, we are making reports for that concern of safety of the child. And I'd say in addition, that desire to connect the child or children and family to resources, though we have a significant capacity to do that ourselves. I think there is that fear of failing to report in some of that liability piece for ourselves as individuals, but also to protect the institution of Denver Health and ensure that we are making reports for the entity of Denver Health and not only for ourselves as individuals. It's for both parties, but we certainly hold roles that have significant duality in them, and that I'm the person talking with the family and saying, this report, I need to make this report for this reason. And I'm generally explaining that, but I'm also the person who's wanting to connect you to resources and provide supports and be a support to you. So I think that, yeah, certainly all three of these take place in this context here in the hospital. And by far and large, we're making reports related to substance use and intimate partner violence from the hospital standpoint, and less of what other professions are seeing later on when they're working with families as the child or children grow. We have from the mother baby unit and neonatal ICU less reports to make of specifically physical abuse.
I think you cut off there at the very end, but that, can you still hear us, Heather?
Yeah, I can hear you.
Okay.
Yeah, at the very end, I just was saying that from the hospital standpoint, just based on the patient population we work with and working with families immediately after the delivery of a child or children, we're seeing and making less reports involving explicit physical abuse or neglect.
Yeah, yeah. And thanks, Heather. Appreciate that. So it's very interesting to hear the different, right? Because I'm hearing you also speak, even reference more that liability piece. Now you're an entity of Denver Health, right? And the challenges there. So Dr. Wells, would love for you to jump in. And then I know Doris wanted to jump in with the question as well.
Yeah, just really briefly, I wanted to sort of hold up a little bit of what Heather said. And thanks, Heather, for bringing that perspective, because I think that's really important. The area around newborns and some federal language around plans of safe care and what needs to happen for infants that are prenatally exposed to substances. Some recent law changes that we have had in Colorado, I think it's softened that. But Heather, I think you brought up a really important point that particularly for this population, I do think that there is a little bit more of a concern about hospital liability and are we meeting this mandate, especially if the baby tests positive, especially if it's an illicit substance. Again, I think some of the recent legal changes that have been made around the definition of, it doesn't have to be a baby testing positive, it's a baby at risk. But I think it's super complicated in the hospital because once that baby is mom baby or discharged from the hospital, your contact with them is limited. And so I do think that that is one place where liability probably plays a much higher role and I think is even more complicated. And I tee that up because I think it's a place where down the road in our conversations, we may have some opportunities for alternative responses.
That's you're reading my mind. I was like, this is ripe for the opportunity of like, so how do you account for those unique challenges, right? That you've just seen kind of like displayed across. Doris, go ahead.
Yeah, I think so. One point on, the risk associated with newborns and drug exposure and all that. That's also a place where we see a lot of disparate treatment, both in practices around testing all moms, which we know doesn't happen. And then the subsequent consequences of that. But one of the things that I wanted to come back to, Dr. Wilson, you mentioned both in your written response and then also in the conversation here, this that there being a distinction between safety and risk, and there being really a lack of understanding around what the actual distinction is and what that means in thinking about whether or not the child abuse and neglect hotline is the right resource for families. So I really want to start with if you could just sort of like for the group explain the difference between safety and risk, just so that there's some level set for the group in terms of what those two terms mean.
Yeah, I think that's probably a definition that someone that's steeped in child welfare should do, because I know that it has ebbed and flowed. Back when I was doing the BSc on safety and risk assessments on a national level, that was probably about 10 years ago. And I know some things have shifted, right? So if we have someone that is a child protection or child welfare worker who can just give a quick Colorado definition, I think that would probably be best appropriate.
Fair enough.
I know we have some folks. I've seen some names, so.
Yeah, no, we don't have that group pinned, but if there's someone else on the task force who is open to clarifying that or defining those two terms for us, I think that might be helpful for the group.
So I mean, the volume 7 regulation for an immediate response, which I think would match up with our safety concern. It's actively occurring and likely to result in moderate to severe harm, which is specific and also vague. Still up.
Can you say that definition again?
Yeah, so it's actively occurring and likely to result in moderate to severe harm.
That's risk or safety?
That is the volume 7 definition for an immediate response, which we then turn into there is an active safety concern. And then impending danger is it's not occurring currently, but likely to occur in the near future and likely to result in that moderate to severe harm.
Awesome, thank you. So like just thinking about that language, like the strength of that language, and you know what we've heard and what you all experience in terms of you know, when professionals who are in the medical field or behavioral health field are reporting, I'd just love to hear your reflection on whether it seems like the needs that get reported match you know, what we just heard in terms of that, what sounds to me like a much higher level of concern.
I would say no, because, and I say, because the way the law is written is reasonable suspicion or reasonable concern, right? And so I think that's, when we talk about opportunities, that's really important. You know, we're sitting here as a panel of experts, and I think it's important that it's hard for me to say what is safety versus risk, yet I'm a mandatory reporter, and it's not something that's trained to. So when mandatory reporter training occurs, at least in the healthcare setting, it's much more about how do you do it? Who do you call? And there's not a lot of clarity around timing, you know, when does that need to occur? I know this is vague in the law. What is reasonable suspicion? And then how does, you know, in my experience, really no distinction between safety and risk in terms of defining what I'm supposed to be getting in the door.
And I think to your point, Dr. Wells, I think part of that training is it's not so important that you know how to distinguish these things, you know, these things. It's if you suspect anything, call about everything. And I think that's part of the issue that we're seeing, is that we're not giving people a shared definition of or shared language. And I think you hit on something a few minutes ago, Doris, like with even the testings of moms, there's an equity in that because it's focused on dominant model thinking, right? If something isn't happening the way that I was brung up or the way that I was taught, it therefore is wrong. And so what happens then is that the difference, right, gets criminalized versus understood, right? There may be, for instance, I'll give you an example. When I was at Adams County, I had a worker come into my office and said that she was going to file a report on a family because a kid had wore the same thing to school every day. And I said, and how is that a safety or a risk concern? Well, kids can't wear the same thing every day. Why not? How come? I said, how do you know that mom isn't washing that same outfit every day? The assumption was because the kid had on the same thing every day, the family was poor, didn't have resources, the kid was dirty. Like they just went up, this one incident went up their ladder of inference and made all of these assumptions about the family. And so I said that at the end of my sentence when I responded, being poor is not a CPS issue. But again, if you're only using the way that you were brung up, the way that you were raised, things get criminalized that shouldn't be. This mom doesn't have a bed for the kid. Well, where does it say in volume 7 that each kid has to have their own bed as long as this kid has a safe place to sleep? So all of these things start to come into play that send families down, you know, this very hard road that maybe didn't have to be in the first place.
Yeah, so I appreciate you naming that. I think that you know, there are a couple of things that I heard. One is you know, so we know that without clarity of, you know, what are the parameters of abuse or neglect that we're actually talking about that warrant reporting, and they're just being, you know, sort of this default position, and you know, this default position that has some consequences associated with it of, you know, just report, here's the process for doing it. We want to make it as easy as possible, and we'll sort it out on the back end. Right. And then the other thing that I've heard from your conversation so far has been around, you know, when, you know, we know that, so in the instances where we know or don't suspect that there really is a serious safety concern, and we want to connect to services, there's not really an alternative route for those. Like this is the route that we have. And Dr. Wilson, I think it was you who mentioned in the survey responses that like there are places where they've implemented 411 and that could be an alternative. So I want to transition a little bit into what might be some of those. Well, two things. One, I want to better understand like what are some of the concerns that aren't really like truly child safety concerns, and from a medical professional or behavioral health professional, you really don't think that they are true safety concerns, but there are some resource needs. What are some of those needs? And then dive into what might be some alternative pathways for families to connect them to services and resources where you really don't have a concern about safety. Dr. Wells?
Yeah, just as we embark on this, I'm going to let someone else answer that question first, but I do want to throw one other thing out around the safety question from just bringing the healthcare perspective, because I think it's also challenging though to ask a healthcare provider to make assumptions about safety in the home. So the flip side of that is to say that I see a child, I'm doing an exam, I'm seeing an injury that is concerning, or a child just disclosed something, sexual abuse, let's go on the worst end, or even let's say I'm really worried about neglect, right? So, and it's, there's something that really rises to, or let's just use Heather's example of a baby that we believe is exposed to substances prenatally or actually test positive, right? The challenge for a healthcare provider is my experience in talking to, or even being the person myself that is taking care of a newborn that was exposed to substances, is to ask me to develop a plan of safe care, right? Like I don't know what safe is in that home. I don't know how to determine that. And I don't have the skills, the capacity, or the resources to go to the home and determine that. So there is this sort of catch-22, right? That says, as a healthcare provider, I've got to stay in my lane of what I do, and someone else is going to need to determine that in some cases. So this is the tension that I think we're trying to wrestle with, right? Like, how does that happen in a system that that does have huge disparities, right? And we know that some of those disparities come from the front end and the door and reporting. So I just wanted to sort of name that, and that challenge around how healthcare providers saying I can't determine safety, right? That's outside of my lane.
Yeah, and it's outside of the information that you will have access to. 100%. Heather?
Yeah, I just wanted to piggyback off of that and say, thank you, Dr. Wells. Yeah, that's certainly the case. I think that we are working with limited information and limited timeframes. We might have 3 women that come in and deliver and want to discharge on the same day and have multiple assessments to do. And then the expectation that a plan of safe care be developed as well based off of the limited information. It's very challenging, and sometimes due to the circumstances or the limitations of staff, it's like, well, you have to make a call one way or another and err on this side of caution and make a report based off of the limited information that you have, maybe with or without being able to engage with the parent due to different circumstances. But yeah, there's certainly multiple things at play when it comes to being in the hospital and trying to work with families and navigate making reports or not.
Yeah, which I think, Heather, for you and for other healthcare professionals that are working with very young children is even more complex, because you are the vulnerability of a newborn, of a baby, just getting discharged when you have questions or concerns, the risk of something very bad happening, I think, is much higher.
Absolutely. And I'm still toying with thinking about safety versus risk. And just lately, a number of families that I have been working with, there has been a disclosure by mom of use of something like 20 to 40 to 50 pills of fentanyl a day. And so when I'm looking at, is this risk? Is this safety? Is this both? Like, which side of the picture do we land on here? And I certainly want to acknowledge the bias that takes place within substance use or toxicology testing within the hospital. I do work with, and I think we see a lot of families that we work with too who disclose use. And I think I'm still just processing and will be thinking about that for some time, you know, looking at that as safety versus risk. But I think what my gut says is that we're looking at like a lot of risk with those families, you know, and having caregivers or caretakers who are actively using, as well as the risk of the child or children accessing the fentanyl or whatever the substance may be in the home.
So I do want to address your question, Doris, around resource needs and what that is. And, you know, when we're thinking about reports, and I think it really is like level 1 families that are struggling to meet their basic needs. So food, clothing, shelter, that sort of thing. I think that is what's hitting up to the threshold. And I think that distinguish between safety and risk, I think if someone, there's these assumptions that get made, right? If the family doesn't have access to these things right now, then, you know, it's an immediate concern, but it's also going to lead to future sort of bigger neglectful type of behaviors from the parents. It could be situational, but I think a lot of times workers aren't pausing to even, you know, sort of unpack that and to figure out if it's a one-time need for a food box, or is there this continued pressure and stress that the family is facing in order, you know, not to be able to pay their utilities or whatever, at risk for, you know, being evicted or whatever the case may be. I have this unique situation in that I oversee all of the community-based services for child and family services. So my therapists are actually in the home. So whereas other folks are in the hospitals, and we're in community, we're in the schools, we're in the homes, we're, you know, meeting them, you know, in juvenile justice places. And so we, you know, we have crossover youth, we have all these families, and we get to have eyes on them in very different ways. And I think that also increases what I said in terms of filing, or, you know, filing a report based on, you know, services and resources. They're in there, they see what the families are deficient at, right? They see that the house may not have, you know, enough food to get them through the week. So yeah, so I just wanted to answer that question, and I'll just pause there. I have so many things.
And they're making those reports then, you know, when they see that a family, you know, has these needs, they're making those reports.
And the thing that I usually push back on my workers with, or because they witness that, you know, Johnny doesn't have a bed, he's sleeping on the couch. And I'm like, that's okay. You know, that doesn't meet the threshold for the definition. I think it was that Nikki that gave us the definition. It doesn't meet the threshold for the definitions that she just said. One's immediate, right? Safety concern. The other one is future projected concern. And sleeping on a couch doesn't meet the threshold of either of those.
And I think that, like, so I think you having that, you know, very deep understanding, I think is, you know, a real benefit to the, you know, the individuals that you have contact with, who might otherwise make a report. I think to Dr. Wells's point, you know, in other contexts, in other settings, you know, not having, you know, that particular, you know, depth of knowledge and experience, and not having enough insight into, you know, all of the things that are happening then inside a home, positions other professional reporters, you know, like doctors or nurses in the medical profession, of just being ill-equipped then to make those kinds of assessments, and determine whether or not, you know, file a report or not. So then the default then, I think, then becomes for those professionals to just report it, because you just don't have enough information. You have some current concerns and you don't have enough information to be able to, you know, do that kind of analysis. And I think, you know, a subsequent question to that is that, should you? Because that's not your lane, right? Like that's not your area of expertise. Which I think is another important factor in this conversation, which I think takes us to then the other question around then what might be some alternative approaches, some solutions to if the child abuse and neglect hotline is and mandatory reporting is not necessarily the right course, what might be a better alternative?
And Doris,
A lot in the chat here.
No, a lot in the chat, and I just dropped into the way that we just kind of wrote this question just for panelists to kind of be a reminder, like, to the, because I do want to make sure, like Doris is saying, we get concrete. So I'm doing a quick time check. We've got about 25 minutes left in this conversation. I want to get a chance for task force members to jump in and ask questions as well for their own, like, kind of understanding, but let's spend the next 10 minutes talking about explicitly around the solutions piece. So I'm going to read this question kind of as we wrote it, and then we can open it up, Doris, if that works for you. So again, to the extent reports by medical mental health professionals are intended to request services, right, or resources for children and families, so not intervention or removal, what sort of alternative reporting method would you suggest? So I want to give you a chance, and then we're going to keep you in that lane because we want to make sure that we have some concrete things to carry away from your experience and your expertise here. So I'm not going to call on anyone right now. I'm going to say who's ready to jump in with that.
I'll just be sort of quick. I'm going to be sort of quick. Dr. Wilson alluded to this earlier. I think a way to a pretty easy way, like one number, right, for a busy professional to access, like, I feel like this family just needs services or needs some supports. I think could go a long way. The other piece I'm just going to add to that, and I don't want to get down another lane, just to respect what you asked, is I think the other piece that's important is feedback. And whether that's a report through the mandatory report or through a service like this, because if that required professional, that mandatory reporting professional never hears back about what was done or what was provided from the system, we fill in the blanks, right? So it's easy to assume either I made a report and something, I thought I was supposed to, but now this family's never come back. So whatever happened was really bad. Or on the alternative, there were things that were provided, but I was never aware of that. So I don't know the outcome. So I would say two things. One is an alternative space where someone could refer for just resources and know that if more was uncovered, it would be picked up on. And then the second thing is some way to know back what happened so that if they never made contact or whatever, now my concern might be rising to a safety level and then I could report that. So I don't know if that makes sense.
Yeah,
that makes total sense. Or go ahead.
No, go for it.
I was just going to say it makes total sense. And Dr. Wells, I don't think that's a rabbit hole at all. I think that actually is a very concrete suggestion of a part of the system that we need to see. So go ahead, Dr.
Yeah, I was just going to say, there are lots of jurisdictions around the country that have piloted and been very successful with implementing what they call warm lines or, soft lines, 411 lines, where a professional who's a mandated reporter can call up and say, here's what the family is struggling with, hasn't reached the threshold of a safety concern. However, they could benefit from services, around food, clothing, shelter, whatever. Where can they go in their county to receive these? And then families are paired with the needed resources that they need. The other thing that I just want to say really quickly, I know this isn't directly to this question, but I think part of the concern is that we get really caught up with compliance versus skill acquisition. And that was the difference with the child protection team that I implemented in Adams County. And by the way, that program is still going strong after 20 plus years. They only worked on eliminating or reducing the child protection issue that the family came to the attention for. That's it. They didn't spend time diving into, solving all the problems of this family. But if mom had a parenting concern, then that's what we addressed in order to reunify and get these kids back home quickly, right? And the recidivism rate in doing that was very low. And so the other solution that I would say is if we are opening cases on folks, that we are truly making sure that we are doing some behavior modification. We are improving lives and families by offering a new skill set that the family didn't have. So we reduce the child protection concern in the first place versus this compliance. Did mom show up? I'm not interested whether or not she showed up. I'm interested in how she learned to be a more safe and prudent parent. And if their intervention cannot do that, then why are we doing that intervention? So I think that's another opportunity for us, connecting family with resources in a soft way, and then also making sure we're giving families the skills and tools and resources that they need to be better protective parents.
Yeah, I think also I just want to say connecting parents to resources in a soft way makes me think about how sometimes when the reports we make are screened out, certain counties have the opportunity or the services to involve their prevention services teams to check in with families and see if they need support. And I think just working with families from the hospital standpoint, it would be nice to talk with the families and be able to do a referral and say, hey, would you be open to working with this team at the county or this individual at the county who could be part of like a prevention services team, or if it's called something else, who is like a point person for resources and support that's an expert with what's available in that specific county. Because I think there are sometimes reports that are made where there is a gray space about if the report actually does meet the criteria for the laws within, to be a report, but there is a resource need. And so just having more options like that would be something that I could see as something we would certainly utilize from the hospital.
I would agree. And what I would add, and this is really adding to what Donna said, is that culturally connected and community-based. Years ago when Plans of Safe Care was put in place, speaking to your population, Heather, we actually did a pilot at Denver Health and in Denver County where we had county caseworkers that were working with either referrals to pregnant persons who were using substances, had no kids at home, so really they couldn't, that was not something that was assigned for investigation. But trying to reach out to families in a voluntary way with diapers and formula and all the things that we think family would like. But I have to be honest, and no offense to my friends in child welfare, the fact that when the knock on the door had to be accompanied by "this is who I am, but you're not in trouble, you're not going to have a case," or whatever, it didn't matter how that was painted. Many families, for a lot of reasons, were reluctant to accept those services. However, I think when those services can be based out of, and I have a health model, so I think about public health, I think about community-based interventions that aren't connected to child welfare, I think are going to be much more positive receiving. There are a few families that engage in the services we provided, but we learned pretty quickly that it didn't matter how we painted it. If it felt like it was connected to child welfare, many families did not feel that they could accept those services and didn't trust. So I agree, Heather, to what you said, but I would actually add that to the extent we can place those services outside of child welfare completely and still have that meet some, assessments around safety or risk, that would be my goal, I think, because I think if we just try to expand the resources that child welfare offers, I just think it's probably the wrong bucket to put our resources in it. And again, no offense to child welfare, I think it also spreads them even thinner than those systems already are in serving those families that have immediate needs.
I came off mute because I had a follow-up, but want to pause there to see if there's anything that Heather wanted to add.
No, I didn't have anything at this time.
Okay, perfect. So when one of the things that you shared earlier, Dr. Wells, is wanting to make sure that this process is easy for professionals in your respective space to make the appropriate referral, and I'm using appropriate, so like whatever is the best route for the underlying needs of the child and family. When we talk about having a more community-centric, not housed in CPS approach, from a practical perspective, how might that then look? Are there then two pathways in your thinking about having another approach for families where we're just talking about resource kinds of needs?
I think there might be. I think that what Stephanie put in the chat is also really important, right? Whatever that other pathway is, not only needs to be a resource, but I think it needs to be, there needs to be linkages, because we expect families to do a lot. And when they come for services, they often may have a lot of other demands made on them. And so one of the things that we're thinking a lot in the healthcare and community space is things like navigators or care coordinators or folks that can really help bridge those gaps and help get folks to where they need to be. Peer supports, I think in many cases, depending upon the circumstances, can be of real value. So I guess my answer to so it needs to be easy in terms of, like, if I, as a busy professional, have to look up 10 different numbers and try to figure out which one to give them, and I just send it home on a piece of paper. We've tried that before and it doesn't work, right? Number one, I'm not going to know where to go. I'm not going to know who to refer to.
Right.
And then secondly, the family is going to say, they leave my office and they've got another crisis to deal with, and they're not able to connect the dots. So I don't know that I fully answered your question. It may be a separate system, but I think there needs to be enough connections that it's really that safety net.
Okay, thank you. And I think one of the things that you surface is that it's like, those are, we have to be thinking about both the reporter and the ease of making the appropriate referral for a family, and also what it means for families, right? Like, how do they connect to services in a way that's not overwhelming and has them going in multiple directions? And I see that we had a question in the chat about the settlement. Is it settlement house model or settlement?
It is. It's a settlement house model. And I think I read somewhere that Casey Family Programs is gonna talk, and I don't know who's talking from Casey, but Eric Finner knows this model very well, and in fact had implemented the settlement house model in his jurisdiction. I want to say Columbus. It's one of the C's in Ohio. I don't want to miscall it, but I'm pretty sure it's Columbus. A settlement house model is a one-stop shop for families, right? It's a place that families can go for resources. It's based from an African-American model, which was when folks were resettling, there was one place that they could go to obtain everything. So whether that was job training, food resources, after-school tutoring, financial literacy, like you name it, they got it there, and it was at one place. So the kids would get out of school, they could go there for after-school tutoring or after-school activities. Mom could be, there, or dad could be there, receiving services for all the things that, again, would make them safe and prudent parents. And it was one place for families to go. It wasn't all this fragmented system stuff, like you go to CPS for this, you go to community-based for that. It was a one-stop shop that really, again, built to that skill acquisition that I'm talking about in order to help families become safe and, prudent, families and parents. So that's the direction that I would go, because it's not any track. It's not a preventative track. It's not a safety, protection track. It is a community-based hub that is really invested in creating productive, contributing citizens. And it's just a phenomenal model. And lots of jurisdictions have tried it and used it and have them. They may not be called settlement houses. That's a really old term, but that's what it is. That's the model.
Awesome, thank you. And I'm trying to track the chat as well. So I think Crystal put in here, think family resource centers. It looks like there is a model that is operating in Larimore County that we could potentially look to find some more information out and share back out with this group as we think about some alternative approaches.
Doris, I'm wondering if we've got about a little under 15 minutes left in the conversation. if folks on the panel want to add anything in regards to like the concrete examples of what you'd like to see. Otherwise, I would love to kind of like open it up to task force members soon. So not sure if we wanted to kind of tidy up, if, you know, would love for you all, anything else to really add around this question, because again, this is what we're getting at around the alternative piece, right? And then I'd say, let's open it up to task force members.
Yeah, I agree.
So anything to kind of like, anything that you've been wanting to say or share based kind of on these questions in this track we're on, Dr. Wilson, Dr. Wells, or Heather, before we kind of open it up for broader questions from the task force? All right. Doris, we good? Want to jump in?
Good. I'm good.
Bring folks in? Okay, cool. I'm seeing a lot of folks in the chat too, so would love either kind of comments you have, questions you have, particular, you know, we've got these good folks here to really speak from their perspective. So what questions or thoughts do we have from task force members? Stephanie, go ahead.
Great. My question isn't so much for task force well, it is actually for Tess, who is with Family Resource Center Association. Would love to hear your perspective and your thoughts.
Sure. Hi, everyone. I think, like Donna Wilson said, I think they were talking about maybe a different model than the one that we use through the Family Resource Center Association, but we as an organization help support 32 family resource centers all across Colorado. So from the Denver metro area all the way through Northeast, Southeast, Southwest, Western Slope, all around. And we're really a kind of one-stop shop community center for families. So they can come for basic need resources like clothing, food, things like that, help with utilities, all the way up to moving to family goals. And so often family resource centers do partner with their county departments to be referred to by county agencies such as Child Protection Services to be referred to, and also have certain programs through the state like the CCR Colorado Community Response Program that helps to move families out of the system into more kind of community efforts.
Tess, can I jump in with a quick question on that? Like, so it sounds like referrals are being made through CPS. I'm imagining that's not the only way to access the Family Resource Center. So could you speak to that? But then also, like, what is CPS? So a CPS makes a referral. Are that because they've opened a case and the referral is part of a case? Or is that because they make a referral and they're kind of hands off from there? Just want to make sure I'm clear on that.
Yeah, so I'll answer the first part. So the first part is that families do not have to be referred. They can access or walk through the door. Often family resource centers build relationships and partnerships with other organizations in their communities. So there is like a warm handoff or like a, hey, check out this family resource center. They might have the needs for you, but families can also, most services, if not all, are voluntary for families. So they're not necessarily like ordered to attend. And then the second part is that typically it's that they're referred more than they are a case that's opened. So in some instances, a family might have a case open and be accessing a family resource center. In other cases, like a county might get a call and then tell a family about the family resource center and to access it, but a case may not be open.
Okay. Thanks for that clarity.
Yeah, no problem.
Thanks, Tess. Appreciate you bringing in that perspective. Sam, I'm seeing you with your hand up, and then so we'll go Sam and then we'll go Chris.
Sorry, it took me a minute to get off mute. I just had a question. I feel like it was Dr. Donna who brought it up, and I'm wondering how the system can balance what a family actually needs versus what providers want them to have. And just that idea of neglect in that lens, I think is important. And I'd love to know how y'all would think about that approach.
I think I kind of alluded to that in my answer as well. I think sometimes it gets really confusing for families as they feel like the finish line moves every time they get closer. And I think the example that I gave is like, you need to attend these parenting classes. And as mom is getting closer, dad is getting close to finishing them, there's another sort of concern or issue that arises. And so now they need to do that too. And so, I think it's really important in the beginning to have very transparent conversations with families about all of the concerns so they really understand what they need to accomplish in order to be reunified with their family, and know that up front, not that progressive sort of, well, you did this, but now you need to do that and you need to do that. So it's this constant jumping through hoops that I think is very frustrating, and also creates that that mistrust within the system that I think, Kathy talked about. Like, people don't want to receive services because they're coming from a certain organization, because there's this historical sort of, fear or unfairness that has come with receiving help in the first place. And so I just think we have to be mindful of that. And it's really important to be aligned, and really know what the protective concerns are. Sometimes families are working on things that were not even identified in the, initial report or the initial call. Or so, yeah, I just think it's important to be co-creating and talking about those things in a very transparent manner up front.
Thank you.
Thanks, Dr. Wilson. Chris, I'm seeing you next.
Hi, thanks. So I'm in rural areas, and when I hear you all talk, we talk about resources, we talk about, getting the people to the right places, but we don't have those places. We don't have those resources. I think there's inconsistencies in how we report. Like you say, well, it's not a crime if they're poor and they sleep on a couch, but yet once they're in the system, they want to ensure that they have a bedroom for that child. So it's inconsistent what we're reporting versus what we're telling them once they're in the system. Again, we're not the investigators, so I'm just like report. I'm a licensed social worker, so that's all we do is report. But again, if we're being solution focused and we send it up possibly to the reporting center at the state level, is there a way that we could possibly sort it from there to say this person, this area, they make that final judgment or call to say this needs to go into a report, or this needs to go into services, the family needs assistance? And why I ask that is because in rural areas with our reporting issues, we are faced with small town politics that don't want to get other parents in trouble. And so if the decision is being made up here to report it, then their hands are tied down here and they need to go and report it. And there needs to be somebody who actually went to the place. There needs to be follow-up. There needs to be something, because we make tons of reports on the same families for various reasons and nothing. I mean, just nothing. And it's not just about cleanliness or poorness. It's about accessing resources. It's about this family needs help. It's about this child's failing in school. And so once we make the report, oh, let's homeschool the child now, so you don't tell school anymore what's going on. It's about our principals and our administrators knowing that they hang out with this family, and so their kid, they don't want to put them in jeopardy because we go to the same church or we're good friends of theirs. So how can we get this to work at a broader level and scale it down in a T cell instead of working from the ground upward?
Yeah, thank you for that, Chris. I'm glad you added some of the additional considerations for smaller, more remote or rural communities, because we have to be thinking about the impact of whatever recommendations come from the task force, not just in terms of what would work or what might work in, more urban areas and larger communities that are better resources where you don't know everybody in the community, but we have to be thinking about what are the collateral impacts or how it would play out in different kinds of communities across the state. Adriana? Oh, we can't hear you, Adriana. You might be double muted because your mute icon isn't on.
Let's come back to you. Maybe
Yeah.
sort that. Then
We'll go to Jade and then we'll come back to Adriana.
Yep.
Thanks. I just had a couple of quick comments. I think what is coming up for me are actually kind of two separate things. I think on one hand, we're hearing comments or questions around reporting for safety and risk, but that's not what the law actually says. The law says you report if you know or suspect child abuse may have occurred or could occur. And so our mandatory reporters are working from a very different line than those internal child welfare definitions, which are imminent risk of moderate to severe harm. And so I just think that we're kind of really looking at two very different lines. And so if we want to change the mandatory reporting to be a higher threshold, or if we like, I just think that there's kind of we're getting a little lost in that. And our current law says you report if this is where you're at. And so that's how people are acting. I think the other part of this conversation is, what then is the middle ground? And I just wanted to put another plug in for Warm Lines. I think Dr. Wilson, you brought that up. Warm Lines are other places where you kind of have those trained professionals that are able to triage and refer to really meaningful resources and supports in the community, but are also able to identify that, no, this is actually more than a resource need. This is a report of significant physical abuse or sexual abuse or something like that. So I just wanted to elevate that because I think we're getting a little mixed up in those legal definitions.
Awesome, thank you. There is for sure lack of consistency around the language that is used in the law relative to mandatory reporters, and then how reports get assessed for safety and risk. So it sounds like some clarification or changes there to align the two might be necessary. In addition to, thank you for again naming Warm Lines as a potential option. Nikki?
Yeah, I just need to respond to that, and I apologize for confusing people. There are so many laws that we are following, and just because it doesn't meet the definition of what I had said earlier doesn't mean we don't go out. That is just the definition of what requires an immediate response, which then indicates there's an active safety concern. So there's a lot more to unpack there. And I just wanted to make sure that people understood that, because I didn't want people to get confused that this is child welfare's law and this is the only thing that they're going out on. So
awesome. Thank you for that clarification, Nikki. And also for reminding us that it's complicated.
I was going to say, certainly something to put a pin in.
For sure.
For that as kind of one of the nuanced pieces as we get into the technical piece on the backside of this.
Yeah.
So Adrian, if you're there, we've got time for you, and then we're going to go on a break after you. So go ahead, Adriana.
I'm hoping my microphone works this time.
It does. We hear you.
Thank you. Okay. I just kind of wanted to follow up with what Chris and both Nikki and kind of the whole group had stated. And I don't mean this to sound jaded. I think clearly across the board, we can all unanimously agree there needs to be more resources. Resources and connecting family with the appropriate resources is the solution. I feel, however, though, that we have spent a lot of time over a lot of years pushing that to both state and federal legislators, and we're still not quite there yet. And so again, I don't want to sound jaded, but I'm just wondering, first, is it within this task force's authority? And I use that term loosely, but is it within our scope to go back to the legislators and really push and say, absolutely, like the key to enhancing mandatory reporting laws is to provide better resources? Or is that too far outside the scope of what we're doing here for? And then, when we're pitching that solution, is this realistic? Again, not to diminish the work that we've done or to jade anybody, but where are we at when we just say more resources?
I can go ahead and jump in, Trace, just for at least the first part of Adriana's question, which is, yes, it's absolutely within the scope of this task force to make recommendations to the state legislature. So if that recommendation is indeed that we need to create, some sort of a warm line, 411 lines, right? Better service provision, we certainly can. To answer your second question, though, about realistic, I think that's up to us. I think we have the ability to say, for example, when Donna provided an example, we actually know this works, right? Or Casey, I know, is doing a lot of work on this nationally, and I think they've pointed me to 5 different jurisdictions that have these sorts of resource lines going up. I think it's imperative for us to do our homework. And that's where the details come. I think really there are some models cropping up, and if we can put our hands on those things, and if we as a group think that those are positive, ways to move forward, we absolutely can put, what I always sort of say, more meat on those bones, right? But I agree. I know as chair, I never want to put forward a recommendation that says we need more X, because that report will sit on a shelf, right? In my experience. So the answer to I think those are the answers to your questions, at least as I see it.
Yes, thank you. That is helpful.
Thanks, Stephanie. So we're at time. This has been a really fantastic discussion. I really appreciate it. Obviously, we could continue on. So I'm just calling us at time here, but I would love to give an opportunity, Dr. Wilson, Heather, and Dr. Wells. I'm going to give you 30 seconds of, again, with these key questions in mind, and really with this continued conversation around these different professions and the different impacts. So speaking from, your experience and your hopes really for this task force, 30-second kind of, not the last time we'll hear from you, of course, but to just kind of wrap up your thinking right now and what you really hope folks are sitting with as we continue on. So I will stop there, and whoever would like to go first, go ahead.
I'll jump in. I'll go really quickly. I think what this brings up for me, I think Jade framed it perfectly, but there is a disconnect between the intent of a law versus the implementation of a law. And I think we really need to get better at connecting research, policy, and practice, because there are disconnects. So we have legislators that sit and they come up with these, mandates and laws. And then we have, organizations that go and they, try to implement them, but there's a disconnect between the intent of the law and the impact that it has once it gets down into the practice level. And so I would really, would love to have this committee bridge the gaps between those things, because I think at the end, if we're able to do that well, we can set families up to really be able to, thrive in our state and be safer, prudent parents.
Thank you, Dr. Wilson. Appreciate that. And you were succinct. So nice. Love it. So sometimes I kick it. I'm like, okay, y'all, I said 1 minute. All right, Heather or Dr. Wells?
I will go ahead and say, yeah, bridging the gaps would be incredible. There certainly is a disconnect, or we're functioning within a disjointed system. And I just want us to keep in mind all of the nuances within our different roles. I feel like especially the patient population that I work with is a very nuanced area, and a lot of the ways in which the laws are written or what the expectations are with reporting and collaborating with DHS, some patients get lost in that. And the neonatal ICU is just one of those areas.
Thank you, Heather. Appreciate that. Dr. Wells, bring us home.
Oh, I'll do my best. Well, I want to start with just gratitude for this group. I think that this is a really important and exciting opportunity to bring a lot of knowledge and perspectives together. I know I'm already learning, and I'm really excited about the potential for what we can do. Just to be very specific about some things from the lens that I bring as a healthcare provider, a couple of things. I think one opportunity is to really think about how do we distinguish needs of families, neglect / poverty / just families having needs versus physical and sexual abuse. I think they're very different things. And I think there's also a category within neglect that rises to that level of concern where we need the support of Child Protective Services, and how do we think about helping continue to support their work. So that's the first thing, right? Like, how do we really think about separating those things? Because I think we're very different conversations. Secondly, I think understanding some terms like reasonable suspicion. Those are in our law, and I think we either need to clarify what that means and get really clear about timing of reports, reasonable suspicion, those things that have been called out in the legislation for us to address. I know we've been talking about, I know the legislation talks about training. I do think that's important. Whatever we land on, we need to make sure that we're training to the right thing, right? So that those folks that we're asking to take on this role, mandatory reporters, actually are trained about what they're actually doing, not just how to do it. And then I think this concept, really of an alternative system, of another way to get folks help. And really lean into what's working in other places, and thinking about creating that structure here in Colorado, I think is probably our biggest opportunity. And I'm really hopeful we can come away with some recommendations that are really going to create that sort of different path for folks that really just need support.
Thank you, Dr. Wells. Really appreciate all your points there, and kind of laying it out that way is always helpful. Doris, excellent job pushing the thinking too. So just appreciate you also in the facilitation of this. But Dr. Wells, Dr. Wilson, and Heather, thank you. One, we're super grateful for you just being willing to share your expertise and your thoughts behind this. Certainly not the last time we need to engage, obviously, with the nuances that you all have named here. So we'll continue to look for opportunities there. But I think this is a great kickoff to the variety of panels that we'll be bringing over the next few meetings. So really appreciate you all. And just a lot of gratitude I'm seeing in the chat as well. So thank you all there. And Heather, excellent job jumping in with some limited information as far as this group. So appreciate you taking the time. I'm seeing the movement of the hospital behind you. So thank you for making the time and just being here and the work that you're doing there on the ground. All right, y'all. So it's 9:44. We've built in a little bit of extra time on the back end. So I'm going to give us still 10-minute break, even though we're a little behind. So we're going to come back at 9:55 and Stephanie will bring us back and we'll introduce our next guest. So again, thank you all for this excellent discussion and enjoy your break.
Great. All right. So welcome back, everybody. I just want to take a moment and introduce our next group of speakers and presenters, Steve Ellis and Crystal Ward Allen from Casey Family Programs. I had the benefit and have had the benefit of knowing Crystal for many, many years now. We've worked on a variety of projects, and when we were setting up this task force and starting to do research about what it is we wanted to present and who could best present it, Crystal graciously and generously offered the information and data that Casey Family Programs has put together regarding mandated reporters and the outcomes from those calls. As Crystal and I began to talk over many weeks now, if not months, it really came back to this fundamental discussion that we have set up now, which is, does the primary intent of mandatory reporter laws match up with the outcomes that we hope to see, right? And so I just want to welcome Crystal and Steve. Thank you for being with us today. Casey Family Programs has I'd say the most robust data in the country, because they are taking a variety of data, pieces, and really creating a compilation of that for us. We all know data keeping is not without its challenges, as is the analysis. But again, I feel very proud that we're able to have the two of you join us today. Just by way of a little bit more background, this group will hear from Steve and Crystal regarding mandated reporters as medical professionals. That is the data that will be set up today and what the outcome of those calls are. In the future, as you well know now, Jordan is setting up a variety of different panels for educational professionals, nonprofit providers, et cetera. And we will be sprinkling this data throughout these conversations over the next several meetings. So with that, I just want to thank you both for being here today, and we will turn it over to you for your presentation.
I'm just going to say hi to everyone. Really honored to be here as part of this. And I did invite my colleague from our data advocacy team, Steve Ellis, to really give a very quick highlight on mandatory reporting or screening trends in general, but then that real focus on those for healthcare and behavioral health professionals. So I'm going to let you take it away, Steve.
Thank you, Crystal. So I'm going to share my screen in a second and kind of walk through some data that we have through Casey Family Programs, just to kind of give a little bit more context to this discussion. It'll be relatively brief. I figured 15 minutes at the most, which will be plenty of time for questions and such afterwards. Or just, I'm hoping that the discussion or the data will kind of just start prompting those discussions, because the data is, as everybody I assume on this this call knows, is not the end answer. It's just the opening. It's just the crack in the door so that we can go deeper into the discussions. Also, as soon as I start sharing, Crystal, I lose the ability to see chat or hands going up or anything else. So if you can just interject at any point if there's relevant questions. I will.
So if anybody has questions, put them in the chat.
Yep, go in the chat and we can answer right there, or we can hold off to the end. I'll let Crystal kind of decide on that piece of it. Okay, I'm going to start sharing. I think I can. Okay, so looks like it's coming up. Okay, Crystal, does it look okay? Full screen? Okay, thank you. I gotta move things around on my Zoom. Sorry about this. Okay. So again, welcome everybody. So just as a little bit of background, so we know kind of where the data is coming from. Pretty much throughout all the slides, the data will come from the NCANS data set, which is the National Child Abuse and Neglect Data System. And the data that we're using in these reports are coming directly from the state of Colorado. We receive the public data as well as direct state submissions. So our data at Casey tends to be a little bit more current than the data that you can find out there publicly available. The first slide that we get into will include also the AFGARS data. And the AFGARS data is just in a nutshell is all the data that's involving those kids that are in out-of-home care already. And so the NCANS, and I'll back up to the NCANS. The NCANS is about all those kids that are screened in for an investigation. And that's a very important distinction in that there are many calls, and in Colorado, about 2 out of every 3 calls are screened out. And they don't ever come, they don't get assigned for an investigation or an assessment. So the NCANS data, the data that we're going to present, is only about those 1 in 3 reports that got screened in because it met the hotline's level of scrutiny to be accepted for an investigation. Additionally, all the data we're going to be looking at is going to be broken up by race and ethnicity. And there is also, I've limited down to only the race and ethnicities that have at least 50 children in care in Colorado, just to avoid some of the sharp jumping around in the data when you get really small denominators. And multiracial will still be included in there. And just so you know that multiracial kids in Colorado, there's about 200 kids that are coded as multiracial. About 80% of those are coded as multiracial Black. So there'll be a Black African-American and some other race also included. And I bring this up because in Colorado, since there's such a high proportion as Black, African-American, and white, is that the Black race line you see on the graphs will be slightly modified based upon that multiracial. So if that multiracial is lower than the Black line, then think that those kids will go into the Black category, which will actually increase the emphasis of that direction of that line a little bit. So just kind of be aware of that as we have that discussion. So at Casey, we always kind of start our discussions with race and ethnicity. We try to lead most of our discussions that way. So I want to first kind of start pointing out is throughout the whole child welfare system, you can start seeing from the very beginning some overrepresentation in different race and ethnicity groups. To orientate yourself a little bit to this slide is this very first column is the general population of Colorado. So you can see in Colorado, about 5% of the kids under 18 are African American Black. And then the percent of those calls screened in, about 10% are Black African American, then 11%, 10% as you go across. In a quote unquote ideal situation, what you'd end up having is about 5% across all of those key decision points. So you'd see about the same representation you have in the general population as you see on these different key points within this analysis. Numbers that are higher than the general population we think of as overrepresentation. So the Black African American population, you can see from the very beginning, 5% general population, all the way to about 15% of all the kids aging out are Black African American. So you'll have disproportionality throughout the whole system. And you tend to see a little bit pretty equal with that next. And then the white is actually a little bit underrepresented, 52 in the general population. And most decision points are all under 50%. So we're going to start the kind of discussion at a high overview, looking at just general screened in, all the reports are being screened in. Then we're going to narrow the focus down into that mental health grouping of folks that are calling in. So as you can see on the left-hand side there, that about 33 children out of 1,000 are screened in for an investigation. Compared nationally to about 40. So Colorado screened in a little bit lower than national in terms of those kids accepted for an investigation or an assessment. But immediately, graph on the right, you can see in Colorado, there's a very strong disproportionality in terms of the race and ethnicity. Black African American are increasing over time, and they're by far more desperate than other children within the system. Over half or double that of other children. So of those calls that are kind of coming in for they're being screened in, kind of who's making it in general. So the graph on the left to kind of look at the top 4 reporter sources and the other 2 reporter sources would include kind of a general bucket of other and a unknown anonymous grouping. I didn't include those because those are the smaller proportions, and I just chose the highest ones. And you can see that legal law enforcement tends to call in most of those reports. Over time, been pretty consistent, as well as family, friends, and education, been pretty consistent over time. But we've been seeing increases of that mental health. Ranging from about 18% back in 2012 up to about 26% currently. And as always, we always like to look at the data, and you'll always find on the right-hand side the data broken down by race and ethnicity. And I'm going to focus mainly on the Black African American groupings because those are the ones we saw in that first slide were the most overrepresented. And so if you're kind of looking and focusing on the Black African American populations, first thing I want to mention, most of these graphs on the right, my range on the axis differ between each of the groupings. So don't be confused a little bit if you see a line seem to be higher than the other ones that maybe it's actually higher. So definitely look at the range 0 to 30% or 0 to 10% to make sure you're kind of making apples to apples comparison. I may forget to bring that up in some other places. But you can see through here that, so of all the Black African American kids called in, what percent are called in by each of those different groupings? And in general, kind of education tends to call in a little bit more Black African American than other groupings. Family, friends call in a little bit less Black African American, as well as the mental health groupings as well. So now let's look at all those reports that were called in, those children that got screened in for an investigation. So what happened to them in terms of a disposition? So what the department investigated and they determined disposition on them. And over time, you can see the substantiated, the kind of orangish line is maintained relatively consistent. So about 27% over time of all those screened in are substantiated. And what we've been seeing then, what changes is those that being unsubstantiated and those going into the alternative response, and almost an inverse relationship is that we're seeing more and more of these cases that are where before being unsubstantiated are now moving kind of into an alternative response type system. And we can also then break that data down by race ethnicity as well. And so we can see that here, the Black African American groupings tend to be substantiated a little bit higher rates. And they tend to be a little bit lower on the being referred or having an alternative response system. One thing that did strike out on me this graph as well is specifically the white grouping. So in general, we've seen, even though we've been seeing increases in the alternative response over time and decrease in substantiations, most of the race ethnicity lines are relatively flat. And what's really driving, it appears at least by this graphic, driving that increasing in alternative response and decreasing unsubstantiation is the white population. So you can definitely see in the white, you see that decline over substantiated and declining on unsubstantiated and more increasing in the alternative response. And that rate, or that, the steepness of the graph is much higher than the other ones. So I thought that was a little bit of interest. So this graphic we're looking at here, it kind of gives you a flow of the system of children that are screened in for investigation. So this is just one particular year. This is 2021. And the left-hand side of the graph, always we're having the reporter sources, is of all of the kids that are screened in, what percent were screened in by what reporter source? So you can see law enforcement screened about 30% and mental health about 26%. And then you follow those kids that were screened in by whatever grouping, and you see what was the disposition of that particular grouping. And the three different types of disposition: substantiated, alternative response, and unsubstantiated. And one thing that was brought up earlier by the panel, which I thought was a very good point, is that these are two different kind of set of requirements. The anonymous, or this grouping of who calls it in, have a level of through laws of reasonable suspicion or suspect abuse. So they're going to call in based upon that set of laws. And the findings of the dispositions on the right are based upon the state set of definitions and laws to substantiate something or unsubstantiate or alternative responses. So it's two different set of laws and priorities that kind of drive some of this. But here, since we're kind of focusing around the medical mental health, I'll kind of explain this a little bit further. So we can see that 26% of the medical mental health of all the children screened in, 26% of them were called in by mental health. And about also 26% of those kids were substantiated. About 29% went to alternative response, and nearly half were unsubstantiated. So even though they call in 1 in 4 of the children, half, 1 in 2, are unsubstantiated. So the majority of those end up falling as unsubstantiated, not substantiated. Where we tend to see more often, and this will be for our future discussion, education tends to be a little bit higher. You tend to see a lot more educators being unsubstantiated than you do see them being substantiated or moving to alternative response. So now we're just going to kind of focus on the medical mental health professionals. So the next set of slides that we're going to look at is not just all of them are broken down. Now we're just focused on the medical mental health groupings. So we've kind of seen this data. If you remember the prior slide, we saw that 26% in 2021 were called in by medical mental health, but this now gives us a trend over time. So we can see from 2012 to 2021, there's been pretty consistent increases in the percent of all of kids being called in by this grouping, medical mental health. And if you look at that data broken down by race, ethnicity, you can see that they've all been kind of pretty consistently trending up a little bit. But then starting in about, I gotta move my slide, about 2019 or 2018 or so, we started seeing a little bit more splitting apart, especially between the Black and the white grouping. So we started seeing a little bit of a change in terms of what is the distribution of race, ethnicity amongst those called in by medical mental health professionals.
Hey, Steve, we have a question as to whether or not the data can be spliced between behavioral health and healthcare or medical, professionals.
Yes, so we are limited in terms of what the NCANs, the categories or the buckets that they want the states to put data into. But yes, the medical and mental health, those are two separate categories. For Casey's purposes, we kind of grouped them, but that can be disaggregated and we can look at those separately at some point if we need to or want to.
Great question. Thank you so much.
Okay, so now we're going to follow in that same pattern we've looked at before. So we know kind of what percent are being called in by the medical and mental health professionals. So what's those dispositions of those called in by medical and mental health professionals? And it's a very similar trend that we saw as a whole. If you remember earlier, we saw that substantiation was relatively flat. We saw unsubstantiation dropping and the increasing of the alternative response. And when you break that data down by the ones called by medical mental health professionals, various also kind of similar trends, except for the what is a little bit higher on ones by medical mental health is the Black African American children tend to be substantiated a little bit higher than some of the other as a whole we're seeing before. But there's not dramatic differences other than between white and other children. The other children tend to be grouped relatively closely together. So again, we're looking at a different flow chart, but we're going to look at it slightly different this time. So I'm going to focus just on the medical mental health groupings. But now how about if we look at a specific report type? So medical mental health, what we're looking at currently are those professionals that called in a child that had an allegation of neglect, and that's the one we're looking at this point here. Now, remember that a child can have multiple allegations, so there can be some duplications as you go through some of this, because as all of you most likely know, is that when a person calls in, they can say, yeah, we think there's neglect in the home. We also think there may be some substance abuse or physical abuse or sexual abuse or anything else.
So Steve, is this just garden variety neglect? Does this include medical neglect?
Great question.
And can you show us the drop-down menu while you're there? Yeah, thank you.
And we'll kind of quickly go through each one of those just so you can see how they kind of separate a little bit, but absolutely. So this is a garden variety of neglect. It's a big open bucket for things to fall into. Now, the state of Colorado may have in their data system, lots of subcategories, but they're required to take all those subcategories and map them to these NCANs big buckets. So we need someone from the state to actually specifically say, well, what goes into neglect? For example, DV, did that fall into neglect? Or does that maybe go into a different category? And the state would have to tell us specifically on that piece if we want to have a discussion around that level. So on here, if you remembered earlier on the last flow chart that covered everything about medical mental health call in about 26% in general. So here they call in about 24% of neglect. And of those of these neglect allegations get called in, I got to go back here. We can see about 28% of those are substantiated and still about half are unsubstantiated. So very similar. And that's mainly because most referrals get called in include a neglect allegation. That's just kind of a general catch-all for most things. But how about physical abuse? So physical abuse, medical mental health professionals call in 26% of all the physical abuse calls. I'm sorry, of the calls coming in by medical mental health professionals, 26% of those include a physical abuse allegation. And a smaller percentage, about 14% are only substantiated. And we have about 60% that are unsubstantiated. And sexual abuse, we'll see that about 31% of those reports by medical mental health include a sexual abuse allegation. And of those, we get a higher proportion that are substantiated, about 28%. But it's more of an all or nothing on this one. So if you remember those other two slides you saw, we had a bigger grouping going to the alternative response. But here it's either substantiated or unsubstantiated. Medical neglect, we're going to, as you might anticipate, that tends to be one of the biggest categories because it's the medical and mental health professionals. So they call in about 48% of all of the reports that are dealing with medical neglect. 15% are substantiated, 57% are unsubstantiated, and 28% are alternative response from those. So we see them calling in a lot of the medical neglect ones, but a relatively small proportion, 15% are substantiated. And the last one is emotional neglect. You see they call in about 30% of those, and 14% are substantiated, and 65% are unsubstantiated on those.
One of the things I'll just add is as you guys, when you look at the slides, Steve has actual numbers for these categories as well. So you're wondering, gee, how many emotional neglect cases are actually called in? There are actual numbers. So you can get a robust look for you data nerds.
Yeah, sometimes the raw number actually matters. So. Okay, so we're going to go just a little bit further and kind of look specifically across those medical mental health professionals. And we're going to look at the top 4 kind of allegation types in here. And again, these are those same 48%, 31, it might be in the back of your memory that we're just looking at, but now we're looking at the data over time. And you can see over time, general neglect has slowly been increasing for this, for the medical and mental health professionals calling in. And they all, for the most part, have been. Medical neglect is the most stable of them. They've been relatively high throughout times. And then if you break this down in terms of by race and ethnicity, the one thing, even though it looks as though Black African American are a smaller proportion, remember at the very first slide that we saw that 5% of all the kids in general population are Black African American. So we'd hope about 5% were represented in each of these ethnicity groups, but they're all sitting right around 10% or so. So it's about double the, in terms of a disproportionality that you'd find in the general population. So sometimes you see a line down low and you think, oh, things are going well, but when you compare it back to a general population, there's still overrepresentation there. So of those that were turned around in the same, the left-hand graph is exactly the same we just saw. And so we're looking at those called in by what type of allegation, but what's the disposition of each of those allegations? And so in general, the vast majority are unsubstantiated for all of these allegation types. The alternative response has, you see more alternative response kind of going from medical neglect. It's been a little bit higher of a proportion. But I got fooled by my same thing. So remember, my axes are different here. So 26% are sitting here for the physical abuse, and it's 28%. So it looks to be about the same percentage wise. So it's easy to be fooled by the axis scalings. And substantiations have been relatively flat, but we've seen that in a few of the other graphs. Substantiation has been flat, where we've been seeing alternative response go up and unsubstantiations going down. So that is a whirlwind through kind of who's calling it in, what's going on. I think some of the discussions and the points that were brought out by the panel members is very relevant in terms of what may be going into the data. And I'd love to hear some questions, and I can bounce around through these slides if we need to bounce around. So Crystal, is there anything you want to add?
So I'll just add that Doris had, Dr. Wilson had also mentioned that, and you can quit sharing your screen if you want, unless somebody wants to go back. She had also mentioned that the alternative response, it was interesting that more white families were being offered alternative response, the rate of per population. So I didn't, a lot of other questions. Does anybody want to come off? Because I think most of them were answered as you went along. I thank you to Michelle, who clarified that Colorado is not allowed to use alternative response for sexual abuse, so that's not an option.
Thanks, Crystal and Steve. Really appreciate that. So I just want to be clear. That's it for their presentation piece, correct? Okay. Perfect. So yeah, seen a lot of great chat or seen a lot of great comments in the chat. So if folks don't have questions, would also love like surprises, thoughts, things that I saw a couple people. Doris, I saw you even make a comment of like, I thought this would be higher, this would be lower. So if it's not a question, would also just love reactions to this data and any nuances that you're kind of thinking through.
So I just want to say I ran the Colorado Disparities Resource Center back from 2009 to 2011. And I must say what we did is we provided data to all 64 counties and we publicly faced the data. So folks knew, what their cultural landscape looked like and who they were serving and disproportionality and disparities. And the data almost looks identical, y'all. From 2009 to 2011. I am shocked. And part of the reason why I'm shocked is because we've given this illusion that we've put this hyper focus around disproportionality and disparities and implicit bias and mandated reporter training, but yet our data still looks the same. We still have the same top 3 reporter buckets. Our data almost looks identical to what it looked like. I mean, it could have been my final report that I put together for the state back in 2011.
Well, Dr. Wilson, the disparities have actually increased for Black kids. Black families.
Yeah, it blows my mind, right? And so there's this disconnect between, again, intent versus impact, discussion versus practice. Yeah, we got a lot of work to do, y'all. A lot of work.
Thanks, Dr. Wilson. Appreciate that piece. Michelle and then Sam.
I completely agree with you, Dr. Wilson. And I would tell you, although our focus is really narrowed on, changing and addressing the challenges of mandatory reporting in this state and not really venturing into the other problems with the child welfare system, they are intricately connected. And I think it's important at some point for this group to also understand that the state has thresholds for what meets the definition of founded, unfounded, inconclusive, has, guidelines around what can go down the alternative response track, what has to go down a high risk assessment track. And so I think that that's information that is important for everybody in the group to have. Even earlier we were talking, Nikki had referenced our, what meets the thresholds for certain response times when it is assigned. Those are things, again, if we're looking at trying to change the trajectory for what gets reported to us and addressing the disproportionality, I think we have to understand, everyone needs to understand, what is the definition of emotional abuse? Emotional abuse, just because it's not substantiated, doesn't mean it doesn't meet the threshold of emotional abuse or emotional neglect for assignment in the state. But then what is the definition that reaches the threshold for a substantiated case of emotional abuse? And the definitions and the requirements for that are pretty extensive and pretty detailed. So I just want to drop that here to say, I think it's important for us all to be able to see and understand those definitions in order for us to properly understand what the problem is.
Thanks, Michelle, and seeing some folks saying in the chat too that was an excellent point. So I appreciate you bringing that up. Sam, we're going to come to you.
Something for me, and I know it's a little outside of the scope of this particular group, but that is important to note is how often, which is from what I saw here, is also comparable to what we see in national data of how often Black and Brown kids are in kinship care and are aging out of the system. And it really just, to me, talks about the importance of community and how are we pouring into communities. So when these young people are aging out of care, they're returning back to their communities. They're not having the same outcomes after they enter foster care that some of the other groups are having. So that was just something I found is in line with national standards of being able to look and see that kinship care and our age out numbers are so significantly higher for Black children, and then also higher for Latin as well.
Well, one of the things I'll just point out is the actual use of kinship care for Black children was less than it was for the general population of kids in foster care. It was higher in the Latinx community. And that's one of the things that I know, Colorado has a brand new kinship navigator practice that's been approved by the feds. And I know that work is going on to make sure that that practice is working and engaging with all families, because it's shown to work. We know that kids do better with kin. So I know there's a lot of work at the state level, and in some of the county areas, they're looking to disaggregate to make sure they're engaging families and giving them that kinship navigator support.
I just want to add, there also has been some federal regulation regarding kinship care in the last few years. And so that's been a big change on who could previously have kinship care and not have to go through all the same hoops has changed so significantly. So I do think that that's become a system barrier, where historically Black people, 1 in 5 were in kinship care. That number's changed, but now you have to go through an entire foster care process, where historically you didn't have to do that. So I think that's something to look at when we're looking at how that data's changed in the last couple of years of who's accessing kinship care. It's no longer as common in Black and Brown communities as it once was, because now there's more system steps.
Yeah, and Crystal and Steve, we can kind of capture those nuances that they're naming, as far as might be a way to weave that back into future conversations as well. So thanks, Sam. Appreciate that call out. Jennifer, I'm glad you came off, because I saw your comment and I was going to invite you in to say a little bit more. So go ahead, Jennifer.
Thanks. That's exactly what I was going to comment on. Is I think, and your data shows this so clearly, the difference between the wide net that mandatory reporting calls on us to cast, because it is, a known or suspected abuse or neglect, versus what's actually substantiated or what even results in an alternative response. I feel like that is such an important data point for all of us as we're looking at how do we make mandatory reporting make more sense, if we use it at all. If we are casting a net that says far less than 50% of reports, depending on who's making the report, are substantiated or getting an alternative response. So I just wanted to name that difference. And again, this goes back to a comment that was made earlier about the difference between sort of the whole child welfare system and mandatory reporting, because those are really two very different things.
Thanks, Jennifer. Appreciate that. I'm looking at the chat too. We'll get Stephanie will answer that question. Well, Stephanie Villafuerte made the point that we're going to have a legal discussion planned. We'll be presenting applicable laws and regulations, and then we'll get back to you on the timing of when that discussion is going to happen. Thanks, Jennifer, for your comments. Appreciate that. Chris, I'm coming to you next.
So I see it was answered. I had just asked, again, being rural, we have a lot of undocumented in our community. I know that when I'm doing mental health with either first gens or undocumented, it's by rule that they don't want to be reported up for obvious reasons. And so I was wondering if there's any selection in here that would have any information specific, which was no. So.
On a related question, I don't know if Trails collects data related to LGBTQ+, but thinking about Sam's comment a minute ago is we know that those kids, have a high level of real serious impact of society and higher level in congregate care and outcomes and all. So I don't know. I'm not sure how it relates to mandatory reporting, but I just wanted to bring it up. Happy Pride Month, all.
I thought the emotional was very slender, especially what was substantiated based on the work I do with LGBTQ as well. So it's definitely, again, in rural areas, it's definitely higher for a mental health issue for youth.
Thanks, Chris. Dr. Wells, seeing you, and then Doris, bring you in.
So two questions, and you might have addressed these. The first one is, do you have data on what are the percentages of actually calls that are coming in? So the overall number of calls coming in from the different mandatory reporting categories, and what are the percentages of different, the racial breakdown in those? That's the first question. And then the second one is, I know you indicated you all can't access what happens to those that are screened out. And I'm wondering if there's another place we can look at for that, because one of the things I'm really curious, one of the challenges for a lot of mandatory reporters is if we don't know what happens next. I know there's a law in our state that mandatory reporters with ongoing relationships are supposed to have some follow-up. It's an unfunded mandate to child welfare. It's expressed very differently in different areas. And so I think there's often an assumption. I make a referral to, based on our conversation earlier, I refer for services, hopefully something will happen, and not knowing what happens. Is there any place that we can capture that? Because I also think it's that group that has opportunity for alternative response or warm lines, those kinds of things as well.
Yeah. So sure wish we had the ability to collect the whole pool of calls coming into the hotline. So for NCANS, the child level file does not include that. It only includes these ones that were accepted for investigation. Now there is an agency file that's also submitted to the feds that does give a roll up and a number that are screened out, number screened in. Casey doesn't collect that report off of it, primarily because NCANS is a voluntary data source. Not all states report that data, so it doesn't really give us a national look at things. And plus that agency file doesn't disaggregate the data to any level. So all we'd be doing is looking at a raw number without really any context around it. Now that's not to say, and I'm sure, I think Crystal calls it trails for your case management system. I'm sure the case management system collects it, and I would think the data could be pulled out if that's something that would be of interest to look at.
I just think it'd be interesting to understand sort of what's coming in the door and then what's getting selected out for even assigned for investigation or whatever. So it's kind of like that end. You got to know the end to understand the data from beyond.
Yeah, it's a great question. And yeah, the integrity nationally of that data is not very good, but it might be good in trails. The other thing that I just wanted to say, Kathy, is you asked about what happens with calls that get screened out. I'm hearing a lot of discussion. I'll just throw this out as a concept for you to think about for future. We heard about 411 lines. A lot of jurisdictions are looking at their 211 lines. And in the 211 world, there is discussion around closed loop information, which means that feedback loop. Dr. Wilson, there you go. And not all, right now, I say not all, but very few actually systems actually track that closed loop, but I'll be quiet.
There are systems that are already managing a 211 line. I'm thinking of Mile High United Way. They have a 211 resource. I don't know how closely that system works with CPS, but I often think that folks that are in the business of working or serving children and families, we often do our work in this vacuum. And I think if we could do a more collaborated, consorted effort, we're all working towards the similar goal of keeping children and families safe, or making sure that they can be the best that they can be. Why are we all doing it, separately and in a very fragmented way? And it's crazy making for families as well. Again, that's why I think the settlement house model, I'm gonna drop a example from Columbus, is the way to go, because it's like a one-stop shop. It's not all these competing systems trying to have families do these multiple hoops. It's like the one hoop, you're at the one place and you can get multiple things done and accomplished in one space. So yeah.
So Chris reminded me of the rural community, and one of the questions that I have is whether it is possible to look at the data, even if it's not like county by county, but like rural versus urban, to get a sense of what nuance might exist there.
So I will tell Steve, and he may not know this, but Colorado has two big buckets of communities. The metro areas, which is 11 counties, I think, and then they call it the balance of state and non-metro areas. And we could probably give Steve the names of those counties, and he could give two presentations for what goes on in the metro counties and what goes on in the non-metro counties. And we could maybe do that for future Region 6. And that's a judicial count. I mean, a judicial region, right, Chris?
No, it's so it's set up like Area Agency on Aging does Region 6. A lot of, so it's just where we're at. I mean, it's Bent, Baca, it's all sorts of Toronto. It's so when I'm looking for information on health statistics, we go by region because it's just not enough when we're going down to a population size of data.
And I just will say, it's my experience, most states have a map on several systems that have different regions. So I don't know if Colorado is more organized.
They don't align, because if you look at like healthcare premiums, it's not Region 6, we're like 8th in the state, you know, so it's, yeah, they don't align.
Yeah, I definitely think I see your note in the chat, Steve, about getting to that you could get to county level, but not lower. I don't think that lower would be better, but I do think that it would be potentially helpful as, you know, this group grapples with making recommendations that are that just appreciate the nuance and differences that might exist in smaller communities versus more metro areas.
Definitely, it can definitely hone your message when you do that piece on education and training, so you can really look to what's the needed discussion and messaging.
Absolutely, thank you.
Sammer has her hand up.
Yeah, I
Yep.
was just going to come
Sam.
back off mute and call Sam.
Go ahead, Sam.
I just had another data question really quick. I know, is there a way when you're looking at substantiated versus unsubstantiated and such, is there a way to look and see if this is a family that has multiple? Is there data regarding the frequency? So of all the calls, a third of them are people who are kind of called on over and over and over, or so on.
In theory, yes. The agency file, well, I'll back up a little bit. We can't do it at a family level, but the child level file we have, it is possible to look to see a particular child in the system, whether or not there's been multiple reports and what is the outcome of each of those reports. We at Casey haven't done that very often, primarily because some of the matching rates between years isn't the greatest. So, but it can crack the door for a discussion, but it definitely wouldn't be something you would probably feel overly confident on our side to make it a, you know, an absolute type statement.
Thank you. I just think it'd be interesting to know kind of the frequency that are the same families, because people are just looking for that resources piece.
Yeah.
All right. Well, we certainly have lots of questions and thoughts and just really appreciate, Steve, I'm seeing a ton of shout out as to like how helpful the way that you presented the data was. So it sounds like you've got a couple of pieces of how we'll kind of like shift a few things moving forward in future discussions. And folks, there's going to be an exit survey too. And so please give any feedback there as well of how this could be even more useful as we continue these conversations. And Crystal and Steve will be sure to share that feedback with you directly, so you kind of have that as well. So lots of gratitude in the chat. So appreciate that. And with that, I will end this portion. So Crystal and Steve, welcome obviously to stick around, and thank you for this rich conversation. So appreciate it. I have only seen one comment for public comment. So we've got about 5 minutes to just kind of have what I would love is if we could just have, so zooming back out, not just in the data, but you've heard this panel discussion today. Then we got into the data to really talk around like, what does this actually look like on the substantiation piece? And so really right now, we just love to open it up to folks. And you'll have a chance as well in the exit survey to kind of just like what's sitting with you. But what are folks thinking about right now? Where do you feel momentum around this conversation? What maybe aha moments did you have today? Or what do you want to just share out with the general task force? So just want to invite task force members to share that. And we've got about 5 minutes and then we'll switch to public comment. And actually, I'll call on somebody because Kevin, I've seen a lot of head nodding throughout this meeting. And so would love to hear what's kind of going on in your brain.
Yeah, I was just struck really, really grateful for all of the data. And I think it confirms sort of what I think about it. And also too, how so many of the disparities run across systems, including the criminal justice system, all of our systems. I mean, I think in the overrepresentation of Black and Brown people in all of our systems and the disproportionate contact from law enforcement, et cetera. And that was a lot of what I was nodding about in the second presentation. The first one I do want to come back to, again, really making a distinction between what the law says about the need to make a report and the definition in what circumstances does, I think, really need to be tightened up and clarified. And this idea that I've heard, I know in the reporting community too, we make reports so that people can get resources, and that is really concerning to me. And that those resources would potentially come with conditions on them that people avail themselves of those resources, just sort of confirms my sometimes feeling or suspicion that this moralizing and preaching to communities about ways to be is happening through this kind of mechanism. And I would really love to tease out the definitions of what actually would need a report if there was one. And I'm really grateful for all of this information.
Thanks, Kevin. Appreciate that. You're what I call an active listener, because I see you doing this a lot when people are talking. So it's easy to pick on you to get kind of what's going through your brain, but appreciate you naming that.
I've told I need to be better about that. So
no, I love it. I love it. I noticed it. Stephanie, you were actually who I was going to call on next. You were reading my mind. So go ahead, Stephanie.
Yeah, I think that, my sort of takeaway today is we already have pieces of infrastructure, right, that we can begin to think more deeply about. I look at our family resource centers, right? I think they've been around for at least 20 plus years. I want to say 30. Yeah. And the truth is they've been horribly underfunded. And I know this personally because I've known the leadership of the association for over a decade. Right. And so I think that's an opportunity. Someone mentioned the 211 line at Mile High United Way that has 7,000 providers on it. There's infrastructure, right? Donna's talked about settlement house models. There's infrastructure. So by way of saying, I'm heartened just as we begin to put the pieces of the puzzle together to say, there are models, there are things to rely upon. I know, Crystal, we're going to talk down the road a bit about national models as well. So I would just say I come away feeling heartened that there are things we can rely upon and frankly should be building upon to make them more successful. The only other thing I would say is I worry tremendously about giving somebody a phone number to a 211 line, for example, and going, good luck, right? And feeling good about that. In our office at the Ombudsman office, right, we have a strong customer service, mission. And we don't just give people phone numbers, right? We call the people and we do these very warm handoffs to make sure people are going where they get. And so I think it's not only important as we think about infrastructure, but it's quality, not just quantity. And I think that's always going to be a concern of mine as well.
I was typing this in the chat, but I'll just come off of mute and say it. Stephanie, I really hope, being that we are all in relational based fields, that we're not just giving people a phone number and saying good luck. Like, that is not proper casework or social work or therapeutic intervention, just handing someone something and saying good luck. So I would really hope that if we make a recommendation that included a warm line, that there would be behaviors that come with that, that would indicate that we are doing exceptional customer service, as evidenced by people forming that relationship and then checking back with families to make sure that they have truly been able to secure resources and maintain them. So I don't want anyone to think that my recommendation was only specifically for a number, because to me, that doesn't even match up with the fields that we are in. It's a relational based field. So we have to build off of the relationships that we should be creating with the people that we serve.
Thanks, Dr. Wilson, for dropping some truth bombs there. Appreciate that. What else are folks thinking? We've got 1 or 2 more minutes. Would love to hear from someone whose voice we haven't heard today. I know there's a number of you on the call, so I won't name anybody specifically, but would love to hear from folks that haven't gotten a chance to share out.
I'll speak up. Thank you for everyone that's sharing and all the information that's been provided today. It's a lot to wrap my head around from the law enforcement side. I guess my takeaway is that definitely the model that we have right now is not the most efficient by any means. And by that, I mean the over-reporting or misreporting, however you want to label it, just bogs down the system for multiple agencies. And so a different model would definitely help alleviate that, because there's some problems that we have right now, and not only in DPD, but maybe DHS and other agencies, is staffing. And there's just not enough, employees, staff to go and work through these cases, that so many of them just don't need to be with us, don't need to be with law enforcement, need different type of resources. They need different venue to really meet the needs of these families. And so if we can just get all those, that group to the right resources and allocations, I think it'll help alleviate, that whole system and bogging it down. So that's my take.
Thank you, Carlos. Any other comments from task force members before I turn it over? Got one public comment. Stephanie was going to bring you on from your comment that you sent to me. Just would love for you to share it out loud. Jade. All right, Jade, you're going to close us out with your comment. And I can't hear you. I'm not sure if other folks can.
Double mute, my
There
fault.
we go.
I think there's also something here around when we say calls for resources to 211 or warm handoffs, that could be the new charge of mandatory reporters. We're not necessarily saying like give a family a 211 resource line and expect them to just go access the own resources on their own. It could be a much more hand-holding with mandatory reporters, not reporting to 211, but really supporting families in navigating the process to find the resources they need, with really that mandatory reporter as their support and guide, but they're just guiding them through a different system. They're guiding them through a family well-being track or family well-being system, not a mandatory reporting system or a child welfare system, unless we meet certain criteria or documentation that truly is safety that the family can't handle on their own. So I just think there's a lot of nuance in what those warm lines or referrals or handoffs could look like. That is where I think this conversation can continue to evolve.
Thanks, Jade. Appreciate that. In the words of the great Dr. Donna Wilson, there's a lot of work to do. I believe that's what you said in the earlier conversation. So that is clear. And this is going to be a really, I'm really fascinated to see how we recap this meeting, because there's a lot of nuggets to pull out, a lot of great things to follow up on. So we appreciate and count on you all reading that and ensuring that we captured that in the right way. So thanks, Jade, for closing us out there. I'm going to pause us here from this discussion. Clearly, we could continue on, but we do have a couple of members of the public. We've got about 5 minutes remaining. So folks, I actually not sure that I saw an official request for public comment, but Stephanie from RMPC, I saw a comment from you. And so we just invite you to come off of mute, introduce yourself, and you've got about 2 minutes, and then we'll go to anyone else in the chat. Thank you.
No pressure. Hello, everybody. I'm Stephanie. I work for the statewide crisis 988 line, and we're having challenges really at our agency when we're hearing allegations of abuse or neglect from callers and the line of mandatory reporting. And so I'm just wondering how, I mean, this obviously warrants a bigger conversation, but when we hear something, how to establish guidelines for staff in reporting when we're hearing allegations in telephonic work.
Appreciate that comment, Stephanie. As you said, it's a much more robust discussion. So capturing that comment, also would appreciate if you could drop your information in the chat to me so that we can follow up appropriately. And if the task force continues, brings that back into a conversation, we'll be sure to link back with you on that. So appreciate your comments there.
Sure, thank you.
Yeah, just limited on time with engagement right now, but really appreciate you being here, and we'll make sure we capture that appropriately. Is there anyone else? I didn't see any other members of the public. Heather, go ahead, Heather. If you could introduce yourself too.
Hi, all. I'm Heather Thompson, Co-Deputy Director at Elephant Circle. We're a birth justice organization. First off, thank you for this robust conversation and for allowing those of us from the public to listen in. It's been really great to hear all the thoughts and suggestions, and I'm a data nerd, so I appreciated that. I had a quick comment and a question. My comment was I really, from our experience at Elephant Circle, want to elevate what Dr. Wells said about some sort of feedback loop back to healthcare providers. We hear that a lot in the maternal health space, that healthcare providers would like to have a better sense of what happens downstream from a report. And that leads to my question, which is, I'm wondering if this task force is going to spend any time talking specifically about newborns and specifically about newborns whose parents use drugs prenatally. As Heather on the first panel mentioned, it's a really nuanced area. And in my experience, it's an area where a lot of our biases and stigmas are very concentrated. And specifically speaking to the data, we already know our current inequitable maternal health and maternal mortality situation makes clear that anti-Blackness is rampant in our maternal health care system. So if we've already got a layer of anti-Blackness systemically there, what does that look like in terms of reports, in terms of substantiations? And I know that newborns removed, at least in the state of Colorado, have a much higher rate of not ever returning home. So I'd love to hear what mandatory reporting looks like in that space specifically, and hope it might be on the agenda in the future. Thanks again for all this work.
Thanks, Heather. Really appreciate it, and appreciate you being here. I will say, Stephanie, just as chair, I don't know if you wanted a chance to just respond real quick around how we do, again, I think we've kind of talked about in this meeting around how we're going to bring in those kind of nuances to this conversation, but Stephanie wanted to give you a chance just broadly to respond to that real quick.
Yeah, Heather, thank you for really, I think, pinpointing that topic. The answer is I do believe this group will be certainly referencing different categories of youth that are brought into our mandatory reporting systems, right? Just because I think those pose their own alternate solutions potentially. But to focus specifically on neonatal circumstances, I'm not sure we'll be going to that depth, but by way of saying this is a very organic process, we are constantly revising these agendas and shifting course. So just thank you for raising the issue, and we certainly will put it into our thinking and see where it takes us for sure. Thank you, though.
Thanks, Heather. Thanks, Stephanie. I'm not seeing any other requests from members of the public, but I'll give it just a few seconds in case I miss someone. Okay. All right, y'all. It's been 3 hours. It sometimes flies by and sometimes crawls by. I think today it flew by. Some really fantastic discussions. So really appreciate your time and attention today. A couple of things. So one, we'll see you in July. Two, a lot of you received emails from Jordan around panel opportunities moving forward. We want to make sure that we uplift the experience and expertise on the task force first and foremost in these conversations. And so that's really the point. You saw that in action today with Dr. Wilson. And so we, and Dr. Wells, and we really appreciate the opportunity to just engage with you all as individuals, as task force members. So if you haven't responded to our emails, please do so, because we'd love to get those locked away. And then we'll have kind of planning calls with you all so we can dive deeper on what those questions are. Also, there will be significant pre-reading for each meeting as we do these panels, because one of the points, I think, Stephanie, you might have made this point, was we don't want to spend too much time in level setting in these panels. We want to be able to get into the really into the ideas, the expertise, and the areas that you really see where there are opportunities. So if we do our work and do our pre-reading of where panelists are kind of coming in on some of these really concrete foundational questions, then we can kind of get into the meat of it and not spend too much time there. So that's the purpose of that. So that's need you all to do that pre-reading. The last thing I'll say is we have an exit survey, which I'm going to pop in the chat right now. We always appreciate and count on your feedback, both for individual elements of the agenda and overall just the facilitation and how we can continue move this conversation forward. With that, Dr. Wells, I'm going to take your request for music, and I'm going to end us on a song this time. But Stephanie, want to give you a chance to close us out with any remaining comments. Doris as well, if you have anything, and then we'll go from there.
Great. Yeah, just thank you all. It was really great seeing you. Thank you for your very robust participation and very smart conversations. I've really enjoyed today and look forward to moving forward with you on this really important topic. So just thank you.
All right. And Doris dropped hers in the chat. All right, y'all. Thanks so much. Nobody send me a message if you don't like this song, and y'all have a great day.